it's important not for me to go too quickly on everything, because I told you this is a basic class. Someone I talked to told me that she's going to be doing her very first cavitational surgery. And a lot of this, with the diagnosis, treatment planning, and surgery of the ischemic osteonecrotic lesion, it's important to make sure that all treatment starts with good record keeping. This is the key to making sure you have informed consent. True or false? All board actions against holistic, natural, biological, and alternative dentists starts with incomplete or poor record keeping. True or false? True fact. My wife, who chose not to come listen to me talk because she says I talk too much anyway, was my attorney against the state board when an action was taken against me because I wrote a treatment plan. I never did surgery on the patient. And our treatment plans are very complete. And on the back, I have 3 things. And number 2 is, go get a second opinion from another doctor. How many doctors tell you go out and get a second opinion? And I don't write this out, but I tell them, and they'll tell you that I'm crazy. But they already knew that. They met me. If a state board decides to start legal action against you, they do not need a good reason to do that. But to be honest with you, with what I saw happen in Arizona, because I had a second board complaint later, and the committee that interviewed the patient for the complaint, I had a treatment plan. It was a TMJ plan. It was very traditional. It was very straightforward and had a timetable that everything needed to be complete in 9 months. And I put temporary crowns on. She felt so great, I didn't see her for over 18 months. And I told her that if she didn't do it, she'd have a periodontal problem on 30, and that we'd have to splint 2 crowns, and there would be a possibility of losing tooth number 30. So we replaced the temporary. She just didn't have time that day, replaced it 7 times, and told her that at no charge. Then I said I was going to have to charge her for it. And then she went ahead and did it, and didn't pay her bill like she was supposed to. And then she had an abscess. And this was 29 months after she was supposed to have everything done. So I tried to do miracle dentistry, which you know doesn't work. And so she filed a complaint. And one of the doctors on the board interview in Arizona asked me, what's the difference between a biological dentist and a traditional dentist like myself? And my answer was very simple. I said, basically, we're the same people. We went to the same institutions. All I do is I take all the records, I take all the health history, you see the periodontal probing, you see the x-rays are all the same that you would have in your chart. Is that right, sir? And the answer was yes, after each one. So I've got this guy's head bobbing back and forth. I got a master's in business. So the thing is, you want your customers going like this. He's my customer now. And I said, the only difference is that I look at how the material that I put in this patient's mouth is going to affect their health. He says, oh, that's it? Now notice, I didn't go into cavitations, root canals, and all that, because all we're talking about very simply here is a patient with a TMJ treatment plan that she didn't follow and agreed to. And it failed just like I said it was going to fail, because I had no control over her actions. And then he turned around and said, you know, I would have done the exact same thing you did. I would have had the exact same results. So instead of being confrontational with these people, talk their language. But you have to make sure you cover all the bases. And this has happened in, I left out Pennsylvania. There's been problems in Pennsylvania and stuff. So make a checkoff list of necessary information that must be obtained during your first regular visit. No exceptions. This is where your problems come in. Oh, they're a friend, they don't need x-rays. How many of you doctors have x-ray vision that you can see the periodontal apical aspect of a tooth through the bone? You are the doctor that does not need an x-ray. At that time, the patient makes an appointment. Have your receptionist explain their first visit. Make sure they communicate and that they have them know that you will have to take in charge for a full set of x-rays if they don't bring their x-rays from their old dentist. I have patients walk in, here's a full set of x-rays. They're 5 years old. I said, that's not current enough. I said, if you were diabetic, would I take your blood count, sugar count from 5 years ago and treat you? She said, of course not. Well, guess what? So we welcome them, we give them a greeting and work with you to achieve good health. In order to do this, we feel that the following information must be obtained. If you have a recent full mouth series, less than 6 months old, of clinical quality, please bring them to your first visit. If you need these x-rays or radiographs, we'll take them. If you have any questions, please ask. Of course, if you're dealing with people who are looking for biological dentists, they of course don't want x-rays because you know they're going to die if they have them. Who gets exposed to more radiation? Your staff and you. How many people have digital now? Anybody have the old-fashioned anymore? Good. 5 years ago it was half and half. Now everybody's going digital. You have the full mouth series. Now, complete oral exam recording all existing conditions has to be there. There was a legal case, an attorney came to me asking for some help because their program didn't save the initial visit. So when everything was done, it erased what was there and didn't have a previous record of it. And the only thing I said, well, didn't they keep a backup? And they were able to go back on backups and find it. They had to print it out, but it was a flaw in the program. You have to have periodontal probings. You have to have a soft tissue exam, oral exam if you're using Visalite or some other means to check, TMJ screening, patient chart photos. How many people take pictures of the mouth and the face before you get started? We're now starting to take a look at people, putting them to a wall and ask them to stand like this and like this with dots. So we can look at them and say, hey, you're crooked. How do you want that smile? Would you like the smile to be like your stand like this, or would you like it straight this way? But they don't see themselves that way. How many people take a blood pressure the very first visit? You have to have a blood pressure. And before you inject, you have to inspect. So you have to have a blood pressure every time they come in and you're doing an exam on them. The only time I don't take a blood pressure before is when I'm doing orthodontic treatment. Proposed treatment plan, if applicable. Oh, and the one that I've been trying to talk my staff into doing is before I present a treatment plan, make sure we get a blood pressure before they see the cost. That was a joke, okay? All right, then a cavitat study, if necessary. So number 9 and 10 can be switched. I hope we make your visit very pleasant, an excellent experience. Looking forward to meeting you. And if I have a patient that is going to have a surgery done and they've signed that treatment plan, they have my mobile phone number on the treatment plan. They have it. I had a guy, he just did a $13,000 treatment plan. Paid cash up front for it. He had my phone number before, we put it afterwards, and I had to call and check on him. I always call and check on my surgical patients the night of or the very next morning, depending upon if I forget. Too much mercury in my brain, I guess. Sometimes I forget. Inform before you perform. Consent forms for all procedures. Before we do a filling, we even have a consent form telling them that before we do a filling or a crown prep or anything, that there's a possibility that tooth could die. I don't expect it to. Inform before you perform. Okay, signed and dated by responsible party, a witness, and the doctor, and date it. Sometimes, I don't know if you can read this, so I'll read it up loud. It's one of my favorite sayings. Sometimes when you cry, no one sees your tears. Sometimes when you're worried, no one sees your pain. Sometimes when you're happy, no one sees your smile. But fart one time, man, it gets everybody upset. Case number 1. Profile. AG is a male, 22 years old. Low blood pressure, thyroid problems, frequently tired, mercury poisoning, environmentally ill, multiple system failures, clinical condition, multiple and congenitally missing teeth, multiple areas of ischemia, osteonecrosis and pano, very frail patient. He is convinced his teeth and mouth are his main problem. This is what it looked like. And we're going to be doing a surgery here on this poor gentleman after we look at the cavitat. This is the upper right. This would be a 4, 4, 4, 3. That's fine. What does it mean? Yeah. Yep. Okay, the question is, do you know if you're in or out of the sinus? I'm going to answer that. It's coming right up. It's the perfect question. Yes, on the cavitat scan, how do you know that you're getting the sinus or not? Okay? Red does not always mean disease in a case. Red does not always mean lack of bone density. A large sinus is not pathological, so see, your question is right here. So you must have a pano to use a cavitat study. So we're going to take that. Here it is. Here is the cavitat. So what you can see over here is the lining of the sinus, and there's the bone. There's no bone density shown in number 1. There's a little tiny piece there. I would say part of that is the sinus, the other part is where the bone is. So it's a combination of both. Johnny?
You said congenitally missing. Was everything missing, congenitally missing?
Some congenitally missing teeth. He had some bicuspids that were missing that he didn't have orthodontics take it out, and he was missing 1 or 2 third molars that never came in. And yet,
was this a cavitation?
Yeah, this was, yeah, I believe these were missing teeth. He never had these extracted. That was the only third molar he had. One of the things that was interesting, somebody had asked, and I didn't bring it up, one of my sons, with the eruption of his third molars, had a lot of ischemic bone behind him, and we did a ALT test, and Boyd Haley called me up after he had done the study and saw the last names were identical, so he kind of figured it was my son. And he said, you know, this is some of the most toxic I've ever seen. So when you do take out third molars, look distally, because as the third molars erupt, the bone kind of dissolves and isn't very healthy. And so sometimes, if you use epinephrine especially on those things, you don't get it cleaned out, that bone will become necrotic again. So you got to go beyond the socket and go back in there with a slow speed. I use a slow speed Cavo surgical unit, and it has its own water supply to the tip. And we use surgical saline to go into that. Next, okay, so we can see the correlation between the two. So what we did in the record keeping was we got a blood pressure. We also get oxygen saturation and pulse. We write down the type of anesthetic, the amount. I described the flap that I'm doing, and I was corrected. I was told that you don't lay a flap, you raise a flap by an oral surgeon because I was using the wrong lingo. What happens while you get in there? What do you find? Any special events? Is it an oral antral fistula that you're up into the sinus or not? If you use a biopsy sample, what lab are you sending it to? And then if you're going to go ahead and use materials in the surgical site, what are you going to place? And put down the serial numbers of that. You keep a running record. I have a Criticare unit where we take blood pressure and the oxygen saturation every 5 minutes. And then sutured with for maximum closure or primary closure. The difference is primary closure, you get the tissues to close all the way together. Maximum closure stops like this and it doesn't go all the way. Patient tolerated procedure well, or were there complications? Recommended treatment afterwards. We use an anodyne light. Anodyne is out of business, and they're coming out with a new product in a few months, and it's going to be a very good anodyne light. It's an infrared. Some people will use Arthostem, which is electrical current. There are many different type of products out there that are very good. Post-op instructions given and understood. Many times we don't give them to the patient, we give them to the person who's picking them up. And we've already, I see something that's missing in here, prescriptions. They were given at the consultation appointment, so that's why it's not on here. But at the consultation and treatment planning, we do the prescriptions, so the patient doesn't have to go get them. Any post-op procedures, and we get a last blood pressure and oxygen saturation and pulse. There was a gentleman in Texas, wonderful state. He took out a root canal tooth on an elderly gentleman who had a very high PSA. It was an anterior tooth. And the endodontist went nuts because the biological dentist said, you know, if you take that tooth out, your PSA may drop. I can't promise anything. The man was given less than 3 months to live. He said, what do I need the tooth for? I'd like to live. And this is a true story because this is the state of Texas, and I lived here for a while. One of the happiest days of my life when I left. Anyhow, he was brought in front of the board as a complaint by the endodontist that he pulled a perfectly healthy root canal tooth. The patient went into the board and said, I asked him to pull the tooth. Said, but he pulled a perfectly healthy tooth. He says, I have a right to take out a tooth. And he says, and I'm healthier today. My PSA dropped from, the guy said 2,000. I've never heard of it that high. But down to 6. You can live with a 6 PSA. The urologist is sitting there asking, what did you do? And his daughter took the dentist to court suing him because the father lived. The judge threw it out. And that's a story given to me by a very dear friend of mine, another past president of the International Academy of Biological Dentistry and Medicine. So, I mean, these things are crazy, but you see direct correlations. But I have this checkoff list on every patient, and I make sure that we follow that, except mine has, did they get their prescriptions, and are they understood? And a lot of my patients won't take prescriptions. You might have some that want to use Sonum products or holistic antibiotics and things like that. That's fine. You still write traditional prescriptions. Do you realize that only 45% of prescriptions written are taken to a pharmacy and filled by physicians? CYA, get in there and cover yourself. And make sure that you write those prescriptions. You can't force them to take it. You're just telling them you're practicing good dentistry. And when I had mine done, I'll tell you something. When Wes Shanklin, my blood pressure was 215 over 145 while I was sitting still. And Wes came in and he did one, which had already been done by Chris Husser, and Chris did a great job. And Wes did the lower, because when I push on that spot with acupressure, my blood pressure went almost normal. When I let go, it went up to 215, so I knew it was time. He went in, he cleaned everything out. Everything went fine. My blood pressure the second day after that was 140 over 80. I could live with that. It was just a coincidence. But I took my antibiotics and I took my homeopathics and filled them out, and I did fine. And a lot of probiotics. Here we are. We're looking at area number 1, or upper 8 if you're from London. And we just make a flap, and we're using a 15 surgical blade. And you take it all the way down to your hip bone, and you just go back in a straight line, and then you relieve around the tooth. And then you take a periosteal elevator, and you're going to prop it. Now, the thing that I have changed since I've done this is right here, I was taught to go into the papilla. Well, my periodontist said, Mike, if you just go straight across here and cut this way and cut that way, you'll save the papilla, you'll be a little healthier, and then all you do is you suture through this and hold it, and it will look nicer 5 months down the line. So I'm learning something all the time from somebody. And, you know, And one of them was at a talk like this, came up to me and said, let me teach you something. And I love it that I can always learn something new. So you take that away, you raise the tissue, and you just take the tip of the periosteal elevator on the maxillary and push. What happens to it, Johnny? Falls in like quicksand. It just goes boom. And it will just fall in there. Doesn't take a lot of strength. Now, once in a while, I will use a handpiece to do that when I know that it's very, very thin and I'm trying to avoid going into the sinus. And I'll take a little burr and I'll cut it a little easier. But that takes, you'll see that and learn it through experience. And what do you do if you find out that you wind up into the sinus? Don't panic. Relax. Oral surgeons do it all the time. If you ask an oral surgeon, they're going to say, oh my God, you got to be careful, it's terrible, it's this. They do it all the time. But they're a specialist, so they know how to manage it. They're dentists that went an extra 2 years, and I wouldn't trust to pull a tooth in my mouth. Okay, so you lift that, and you start getting some pressure. You go in, and it just pushes straight there. It disappears. You obtain your first biopsy sample, and you get samples. I'm spooning this out, and I place it into a plastic container. Now, I use a lot of homeopathy, and I use something called a wave machine, which picks up frequencies. And I use a lot of homeopathic surgical mixtures that are already mixed up by different companies. And so I'll take the sample and I'll put it in one well of the wave machine, and the other cell has the sample bottle, and we'll take the frequency and invert it and shoot it into the bottle. And that will give me a specific remedy for that patient against their own diseased bone. So we go in here, and now I'm going to start cleaning. And this is a Cavo handpiece. I like Cavo. It's been pretty reliable. And it directly puts water. There's a little spout here. It puts water at the tip there, and it keeps it wet. And we use surgically saline supplied water. It pumps, and it just keeps on going. And you just gently go out and go deep. This turned out to be about 15 to 20 millimeters deep. And it was very simple. That's where it buried in, and we took a ruler and we measured it. And so basically, we just cleaned it out in a very feather manner after I got my biopsies. And I just kept moving it gently and gently. Sometimes I'll stop and I'll just feel. And I'll take it all the way up, and then I'll back off a fraction, turn it on, and just very lightly stroke without pushing up. Because if you push up, you'll wind up right in the sinus. You don't need to do that. And you just artfully and very tactfully, like you're painting, stroke easy. Very, very easy. No, I speak up. Approximately 1 to 5 millimeters of bone, depending upon the area. What you'll find out back here, especially in a past extraction site like on 1 and 16 or your 8s, is if you gently go back and you keep on pushing, the bone is very, very soft. You want to hit a hard surface. And what is very, very difficult when you start doing the maxillaries is many times you'll find out that you go too far and you wind up in the sinus. Don't panic. Just stop pushing, come back and clean, and then you're going to clean it out with hydrogen peroxide or ozonated water, and you'll use something called a Coloplug from Calitech, and you sew that in, and the blood will form on that and form a new sinus floor. So there's your hydrogen peroxide or ozonated water. I'll use both. And now, something that's not in here that I do a little differently between this step and the last, does anybody else have the toy called Periolase? Periolase is a company out of California. It's a laser for periodontal surgery. Very expensive. excellent training. Doesn't pay for itself, I'll tell you that right off the bat. But I'm using it in surgeries, and the periolase has a 1064 frequency. And I go into every surgical site now, and I flick the bone. This generates bone, and will cause bone growth. Yes? I don't think it would hurt. But all I can tell you is that this thing literally goes in with the light fiber, and you hit the bone with it, and you're flicking it. And it's a whole course on how to do non-surgical periodontal surgery. And if you have the funds to do it, I would do it for your patients. But it is very taxing to do, and you have to sign waivers that you won't have your hygienist doing it, or you won't teach your associate to do it, because they want $20,000 to teach them how to do it. And it does work, and we're seeing regrowth of bone, especially from the canine in the mandibular area. It's fascinating to see somebody get 8 millimeters to 10 millimeters of new bone grown there. But there's a lot of steps and everything else, and they have patented the process. So like I said, it hasn't paid for itself that way, but in surgical procedures, it's nice to do. And I would use any kind of laser before closing. Penty?
Like surgeons often use some filler material in the socket.
We're going to go to that in a second. Yes? I'm just using brown bottle. No, it's not diluted. We just take it out of the bottle and put it in. I've been doing that for 15 years. I was told 3 years ago by somebody that you're going to harm a patient by doing that. And I've only been doing it for 15 years and never had a problem with it. So I'm an animal of repeating things and trying new things. And it hasn't hurt anyone yet. Now, you asked, the question here was, what do you put in there? We will use something like Osteograph, LD300. It's placed in a glass tube. It's hypoxyapatite. That's one thing we'll use. We're tending more to use something else, and I'll show you that in a second. I think that my entire presentation, I was told, was going to be on the IAOMT website, so you can get all this information. And you have my email. If you ask me specific questions, give me a few days. I'm only 300 emails behind. But I'll get there, and I'll send you that, especially if you want that presentation that I did last hour. I will use Sonum products, Pleonot, Neg, Arde, Quint, and I'll use Tramiel. And they come in carpils, and you can place this directly in. They're injectables. I love ozonated water. It's very good. The little pointer pen that I'm using is a 0-point laser that if you want to taste something different, borrow my laser and do it in your water. There's a blue light and there's a red light, and it changes the consistency and the angle of the H2O. So the hydrogens are bent back into a 103.5 position, changes the taste of the water. I do that in the laser in the area too, because it goes back to the natural state. Lights are wonderful. So I'll use all these little alternative little tricks and go from there. So we place that. Now these are little beads. Then we take color tape. Color plug and color tape is the same material, only this is like a very flimsy piece of cardboard or paper. You place it over the osteograph, which is these little granules in here, because we call them afternoon delight. They fall out a little and you have some crunchies. So by putting that across the top and closing it, then that will hold it in a little better. And then, come on, we place it, and then we're going to suture it. And I place a lot of sutures. I make sure it's as close to tight as possible. If you notice, over here, I have to put the papilla back. And I really appreciate not having to do it that way, just having this straight. But I have a lot of sutures placed to keep it tight. So in the record, final entry, I have a blood pressure, oxygen pulse, pulse and oxygenation saturation. Place the patient on an anodyne light for 1 hour, 10 units. If not done before surgery, prepare all prescriptions and explain. Make sure patient understands post-op instructions. One of the big problems I've had is patients leave the gauze in for 3 days and use the same gauze because they didn't know that I told them take it out every 15 minutes. So make sure that they know to take that gauze out because it can cause an infection as a result of that. Always record patient tolerated procedures well or patient had complications. Did you ever get a note back from an oral surgeon? Patient had a complication and the patient comes back and tells you they wound up in the emergency room while having surgery in their office, and all you get is this little line, patient had complications. It's like the bisphosphonates say there might be dental complications. You heard the story about one of the first oral surgeons to discover what that complication was while extracting tooth number 31. It was a single tooth on the lower posterior, obviously right. Then the jaw fractured in 2 spots, one here and one up by the condyle. After he cleaned up his pants, because he had a little bowel movement, he came back and tried to put it back together again and couldn't. So I always wonder what it meant there were complications. If you have complications, write them down. It's really important. And date it, signed, and if you have a time. Also, if you're using nitrous oxide, how much did you use? What time did you start? What was the combination, the percentage, and the flow? So it's recordable. Yes? Okay, what type of antibiotic? It depends on the patient. If they're allergic to something, I'm obviously not going to do it. Z-Paks are very nice because they're quick, 5 days. It depends on the patient again. Is it going to be augmentin, clindamycin? Will it be amoxicillin? Very rarely do I ever use penicillin. Keflex. Okay, I think you said that when you were taught to graft that you used tetracycline? Doxycycline? It's another good one. I have no opinion, I don't know. That's the other thing that I always found out. There's nothing wrong with not knowing something and admitting it. It's better to do that. Now this carrier is a special design. I used to have an employee. She thought it was more important to try to adopt kittens than it was to do her job. And I told her she couldn't adopt cats through the office anymore because the other employees were complaining they were doing her job. So I brought this in and I told her to carry it away. And and we had a letter for her to do her job, and then the next Monday she quit, telling me that it was incorrigible that I would even think that she couldn't adopt kittens while she was working. And I said, do it after work. So she got carried away along with the kitten. It's a tabby toad. It's also applied for dogs if you like it. By the way, I have a cat as a pet, and she's wonderful. She came with my new wife. She runs the household. Not very well, because the cat will put it on us. It's cute. Okay, case 2. MB, 58-year-old male, pain lower left, first molar, abscess tooth. This gentleman comes from Tucson up to see me in Phoenix. His dentist is a biological dentist in Tucson, didn't want to touch this. And we're just going to concentrate on 19. I think you'll see at the beginning of this an implant on number 6. I took that implant out because he had really bad problems with his right hip. And later on you'll see that that's gone and he's put a bridge in there. And since that's been gone, the hip is fine. And you'll see in the pano, I want you to look at that area, the upper right 3, that there is implant material there and what you'll see afterwards. Of course, we have this, all patients coming in For a cavitat 4th generation, before the cavitat appointment is started, you must supply a full mouth of x-rays, absolutely no exceptions. Because you can't, without a pano, you can't use a cavitat. Again, we have all the checkoff lists that we went through before. No need to repeat that. There's your checkoff list. And this is, my staff has to check and make sure that we have it done. Because I'm a ditz. I am so ditzy. They can't believe that people would come to a convention and listen to me talk. So you have a health history. Regular patient health form is updated. Blood pressure, all radiographs are current. And my office manager makes sure that we have every PA also. And now she's teetering a little bit on that with the 3D because we get better pictures from the 3D because we can go back and forth and look at something. Okay, so complete oral exam, complete periodontal, soft tissue, oral cancer within normal limits, TMJ within normal limits, blood pressure normal, cavitat study recommended because of the health history. We do have the leukoplakia, we do have some mobility frications. Beginning blood pressure, pulse is taken. Now remember, I said he was sent to me by a dentist in Tucson. We still took the basic records. He did send us up stuff that was incomplete. We made sure it was complete, and when we had that done, a second copy was made and sent to his office, including the x-rays. Since they're digital, we either emailed them or we made a disc, one of the two, I don't know. And so we have the vital signs. As you can see, there was the implant there. This is the tooth that we're looking at. That was one of the first panels we had on him. We did a cavitat on it, recommended treatment, and he disappeared after that. But you want to keep excellent records. In this form, I want to thank Ingo Mann. He's also a member of this organization. He's up in Milwaukee area. He designed this. And we use it every day because we can put a score of what the tooth number is and the condition. We have the name, date, myself, and then I can't read that, but we put down score 0 to 4 and explain it to the patient. And then that's what it looked like, and this is how we scored it. We had a 4, a 2, a 4. You can't see it as well as you'd like on the back side. 2 and 1, 1. That's what it looks like in a little better picture. So we combine it. Now, if you take a look, what's missing? The implant. Remember I said we had an implant there? And this is some of the artificial bone that we placed. It was a huge, huge defect. Let me go back a second. Yeah. Okay, so I got to move a little quicker. I want to make sure that we got that, so we might be a few minutes. But I know Phil and Robert, they're behind too. So they always were. Surgical site, here we go. We're going to go through this. By now he's lost the crown. Tooth is in worse condition. He knows it has to come out. He does what everybody else does, is procrastinate. Now we're missing the crown. That's gone. Cavitation here. Here's the cavitat, up to date. We go ahead, we're going to raise a flap. I say laying a flap, I was wrong. Retromolar pad to 2 teeth before the surgical site. So we're going to come out here so we take the tissue so it doesn't rip. Then we're going to lay the flap. And now we're going to expose that bone. And of course, this thing's in the way so you can't see the abscess very well. But now you can see where the abscess ate through. And there was a decision made. I wouldn't make the same decision today, but this bone was in such bad shape, I cut it so I'd have control of that cortical plate because I didn't want it to go any further down, being ripped out, because that whole thing would have just totally gone, and you'd have a huger defect. So I went in, and we released that. Today I would use the origami method, which would have been, I would have split the tooth in half, and I would have taken each root with it and tried to keep as much buccal bone as possible. So we learned. Okay, so we go ahead and I take this thing out, loosen it with an elevator, and then we rise it up with cow horns, and we look at that and we say it's a boy tooth because it's got long roots. Then we throw it in there and it bites the dust. And depending upon where we're going to send it, we go. I use a rongeurs, take the interproximal bone out of there. It was very, very soft. I could have done it with a burr. I could have probably done it with hands, but that controls it a little better. Take that out. Then we start scooping the abscesses out. And the abscess was present. You could see it from overhead. This is all abscess tissue. And we start spooning. And we're spooning it out and just keep on moving. And then, if you look down, you can see that that whole thing is one big hole. That's going to fill in. As long as you got the cortical plate there, that whole area is going to fill in very nicely. Don't leave any of that garbage in there. And now we're going to 17. Now, the one thing I didn't get a good picture of before I did this was when we took it back, out here, you can see a red dot there. There were red dots all the way around. And all I did was cut and connect the red dots. That's really important when you're doing a lower, is connect the red dots. And you'll go through. Sometimes you sit there and go, oh my God, how deep is this going to go? It always goes into a void. The only thing that you have to realize, and this is why I did this picture, is look at how it faces buccally. The biggest mistake you're going to make clinically is you're going to go lingual and you're going to be into the tongue and the soft tissue. Err to the buccal. Go out to the buccal. It's always there. And if you want to see that, we can show you some 3Ds. It's always to the buccal. And so we start cleaning that out and take a round burr. Clean it out so you can see it. Make sure you can't see through a wall, you can't see through bone. Make sure you can see the whole thing. And just keep cleaning. And go in with the burr, scoop out your samples, and you'll see the relationship and how big that actually is. You know how big those third molars are. They didn't clean out the periodontal ligament, and as Leo's came to me, he says, well, what about the periosteum? That's the periodontal ligament. Periosteum, that whole structure, is the same thing. And we as dentists would know that, but the layperson wouldn't. So it's really important to listen to what your patients say, because it doesn't matter if we understand ourselves, it's the patient has to understand what you're communicating. Try an exercise with your staff. Ask them to do things like draw a line down the middle of the paper, put a dot above the line, put a dot in the middle of the line. And you'll find that people put dots everywhere. They don't even know where the middle of the paper is. Our consultant did that with us to see who was listening. And out of a staff of 13 people, there was only one person that got all the directions exactly right. And the surprising one was me. Because he said, put a line down the middle. I folded the paper in half, made a thing, there was my line. All these other people are guessing where the middle is. So, people don't hear what you say. You got to make sure they do. Remember, do not exit on the lingual plate when entering the third molar area. A lot of people are going to be digging here. Look what's there. The tongue doesn't like a burr in it. Doesn't like to get cut. And by the way, I want you to know, I have done this. Okay? I have done it. I love it when patients come in and say, you're the best. Garbage. I just make more mistakes and learn from them. So then we place the collotape, and we place it over there. We had used on this gentleman plasma-rich protein, which is a little different. You draw their blood, and then you take their plasma out, and you pack everything together and throw that in. That really is a sophisticated, great way of doing it because they're healing themselves. And then you don't need to have this on there because you got a clot formed. But we did both. So when you look at this, this is what we had in the tube before on the upper. We took this and placed it in this patient as a bundle. And so it worked out to be really nice. We placed it, put the graft material over, or the grafting site, the collotape, found out it wasn't needed. but it sewed up really nice. I use Vicryl sutures because I have lesser reaction. I found with silk sutures, a lot of people had immunological reactions and didn't heal as well. So that was another product. And this is right after the surgery. This guy was great. He knew we were teaching. So over here, you got this and that. See, they're almost done. And we got this. So you can see the materials in there. The biopsy report, non-suppurative pulp necrosis, subacutely inflamed periapical cyst or an abscess. Okay? You're damned if you do and you're damned if you don't. Wes used to do a class on this. Unfortunately, he's not doing it. Here are the membranes that we use. If you want this, you can ask for me to email it, but I think it's going to be on the website. You have your suppliers. And then the harvest, which I didn't show, and I want to thank the IAOMT staff, officers, and members. God bless you all. This is a gentleman who was the head of the American Academy of Biological Dentistry. This was outside Phoenix when we were doing a Jeep run, and stopped and took a picture. And he had a dream at biological dentistry, and many of these founding members of the IAOMT know him or knew him when he was alive. He was a great person. I like to always give thanks to him because he was one of my mentors, and I hope that maybe one day I can help other people get involved in this because it's for the health of our patients. Thank you.